Starting. Oh gosh, right, okay. Little red dots coming on, so that must mean it's working. Brilliant. So I'm just going to share a really very quick couple of slides for anyone that's new to the community, just so you can get a sense of who we are and what we're trying to achieve. And then we're going to pass on to our guest speakers for today's session. So I will attempt to share again, fingers crossed. I think that's worked. Is that okay? Well, thank you very much. Right, I'll just whiz through a couple of things and then we'll hand over. So for those of you that weren't able to make the last session, we did record it, and the presentation is available through those links, and we'll send these out, as I say, the slides as well. And we're also starting to upload various bits and pieces, and Tiffany very kindly managed to get it on Futures for us. So that also will be shared, and that's a link to the Futures page where we will start adding things that you share with us, and the insights and things from the webinars and the other meetings that we're running. So we'll try and keep it as a bit of a live repository for everybody to access what they need when they need it. That's a reminder to me to record it. So there we go, job done. I feel like I've achieved something today because I've remembered to press the record button on Teams. So a little bit about us. So we are the Improvement Academy based out of Bradford Teaching Hospitals, and we are delivering this programme in partnership with our Yorkshire and Humber Health Innovation Programme and with our colleagues at NHS England. And basically we're a bit of a mix. I'm a nurse by background. Sally Ann is our consultant ED, who's also Vice President at Archem. Lizzie, who is turning up in a minute, is a GP, but also works with us here, and we have project managers, nurses, physios, all sorts of things here. So we are the sort of team helping to support the work, but very much working in partnership with yourselves and learning alongside yourselves through this test year. So the learning community, why we're all here today, this is kind of what we set as our aim for it to be very informal. We don't really do formal at the IEA, so it's a good job that we set it up to be informal. We want it to be a safe space, so problems, challenges, please do share. I'm sure even if people aren't saying them, we're all often thinking the same things. It's inclusive. We open this to everybody, which is why, as we always say, share the invite wherever. Anybody who may be interested in coming along, we're all welcome. Our focus, as we said, is very much on learning, and throughout this whole programme, it's very much around learning what works, but also what doesn't work and why. That's just as important. We are happy to host meetings on subjects of your interest, concern, but please do tell us what they are, and we'll put a reminder in again at the end of the session today. I think one of the best things about informal communities such as our learning community is the peer-to-peer support. We all think we're the only one struggling, and sometimes just hearing somebody else say, actually, I've been worried about this as well, is a great leveler and a really nice thing to do, because we all worry that we're behind constantly, even though often we're not. And I think really importantly, what we'd like to do is celebrate with you as we get those small wins, as we find those pieces of learning, those things that work well. I think it's important that we celebrate what we do and what we do well, because we never do enough of that in the NHS. So that was one of the focuses also of the learning community. So anything you've done well, good practice, please do let us know. We can share it through this, we can capture it as a case study, whatever works for you, but we really want to be putting that stuff back out there rather than focusing on some of the challenges and negatives. A bit more of a balanced view, I'd like to think. So we have a rough agenda for today. Rebecca is going to talk a little bit about where this came from, almost like I always feel it's quite useful to take it back to the original thinking when we're struggling with something, to think, well, why were we interested in the first place? Where did it all come from? And then Dina very kindly has offered to talk about some of the work that's been done around the PWQ in her trust in West Suffolk, not in the ED, but really what we've learned about the general. And then we can have a discussion after those two sessions around what are we thinking, what ideas have people got, if people have started testing, what are we learning, and what sort of help can we all pull together to sort of get this off the ground and think about how it can work in that session. Then if we've time, I'm just going to do a really brief update. It's a summary building on what we shared last time about what we've learned so far, what themes are starting to emerge, and then a bit of a chat about what you'd like next with this learning community, what we can do together, what support you want really, and close. So probably about an hour and a quarter to a maximum of an hour and a half today. And I just put that quote in because this was something somebody said at the last learning community when we were talking about the various different components and what people were thinking. Somebody said, don't turn PWQ into another tick box. And I just thought that was really insightful and really, really, really important. So I think I'm going to use that as a sort of bit of a strapline on various different things. But I was putting this agenda together and thought, yeah, that is kind of the core, isn't it? We don't want to do that. We want to get this into something that's really valuable and makes a huge difference. So I'm keeping that at the back of my mind. So I'm just going to keep popping that up and sharing that with you all. So I'm going to stop sharing now in the vague hope that Rebecca's computer's working and you can share, Rebecca. So I'm going to stop sharing and push it over to you if it's working.
Thanks, Mel. I'll definitely give it a go. Okay, let's see whether this... Can everybody see that? Sorry, I'm just checking. Can everybody see the presentation or not?
Yes.
Yeah.
Oh, brilliant.
It's not in SlideShare, Rebecca.
It's not in SlideShow. Okay, I will put that in SlideShow. Okay. Sorry,
it's still in edit, but it is readable.
Ah, okay.
There's always at least one glitch.
Let me try once more, because in my slides it is showing as SlideShow. So let me see if I can work out what's going on there. Start again. Right. Let's try that one. Sorry, just chatter amongst yourselves. I'll have a little sing while I see if I can get this.
Well, having a sing, that would be a different sort of meeting, wouldn't it? Have we got any choir mistresses here or masters? Anyone in a choir?
I only sing in the car on the way to work and back. It's a long journey.
Okay, right. Now, this is the best I seem to be able to do. Is that still in?
It is readable, but it's in.
You want to have a go yourself? I don't know whether it's laptop I'm on or something that's not allowing me to do that, but I don't seem to be able to show the full screen. Let me just.
Okay.
That's presenter view, but that's not. I'll stop sharing and then you can.
Yeah, I'll have a go. There's always at least one Teams glitch, isn't there, in every meeting?
I will have to do the old next slide, please.
It's okay. Right, it's full screen on mine. Is that working for people?
Yes, it is.
Fantastic. There you go. Brilliant. Thanks so much, Mel. So I'm Rebecca Lawton. Thank you so much for inviting me along today to talk to the group here, and I'm really happy to answer any questions at the end about the PWQ and any of the broader work that I'll present today. I'm a psychologist by background and director of the NIHR Yorkshire and Humber Patient Safety Research Collaboration. And I think I wanted, Mel, if you could just move on to the next slide, please. I just wanted to talk to you before we get into the details of the PWQ about where the kind of idea for even doing this originated from. I think it's probably important to describe a little bit of the background to this and the thinking and rationale for doing this work. So we in the Yorkshire and Humber Patient Safety Research Collaboration have been doing work around patient involvement in patient safety for many years, starting with a large programme grant back in 2012. And we've been trying to do various different projects, all of which come together around one central focus, which is how do you involve patients in safety in different ways. So some of the papers that we've published over the last few years are here on this slide. Some of them have looked at how you involve patients directly in facilitating the safety of their own care. So for example, we've done a study looking at how patients can be involved in safety netting for earlier diagnosis of cancer. And we've done a project looking at how older people can be more involved in their care during their hospital stay to support their ability to manage their care when they leave hospital, which is a time of very high risk, particularly for older patients, with about 17 to 18% being readmitted in the first month following their discharge from hospital. So we've done that kind of work that's really looked at what you need to do to support the involvement of patients in their own care and facilitating safety of their own care. But we've also looked at how you might involve patients in improving care at a unit, ward, or organisational level by providing feedback about the safety of the care that they receive. So, for example, could you learn from patients how safe a particular ward or hospital is? And can you use the information patients are able to provide to make those wards or units safer? And so we have run randomised control trials in this area, one that I know Sally Ann was involved in and was talking to me about before we started this seminar today, was a trial called PRAISE, Patient Reporting and Action for a Safe Environment, which actually asked patients to feed back on the safety of the care that they were receiving while in hospital. But they fed back on some really interesting things that you might not have expected patients to be able to comment on, like how well trained did staff seem to be? Were they struggling to find the equipment they needed to do their job? Did they seem to know what they were doing? Was supervision good? Did teamwork and communication seem to be effective? So they were providing us with information about the factors that actually contribute to patient safety errors and incidents, as well as providing us with information about the incidents themselves. And so we were doing this work, and we started to think about different ways that patients might be able to be involved in their care. And as deterioration in hospitals was such a significant problem at the time, we started to explore what the systems and processes were for involving patients in their care. Next click, please, Melanie. And so we began a piece of work looking at, well, is there a role for patients and relatives in escalating clinical deterioration in hospital? And what do we currently know about that? And we did that by conducting a systematic review of published and actually grey literature. A lot of the literature at the time was hospitals just reporting on their websites what they'd done to support patients in escalating concerns that they might have. And we reviewed that literature, and what we found was there were lots of systems, or at least there were a few systems, that supported patients to call for a second review if they were unhappy with their care. But there wasn't anything about asking patients routinely in their day-to-day care about how well they were feeling and whether they felt that they might be deteriorating themselves. And so it was at this point that we thought, perhaps there is a gap there and we maybe need to do something about it. But I have to say, this was well before Martha unfortunately died in hospital care, and Martha's Rule was not in existence when we were doing this work. Mel, next slide, please. So in general, some of the things we've learned about how you involve patients in patient safety, and some of these things are useful for Martha's Rule and the PWQ more specifically, are on this slide. And I'll let you just have a minute to read through those. The general takeaway messages from that is patients are very happy to be involved in their care, but they do need a bit of encouragement along the way, and not all patients will find it as easy to do as others. So there are wide variations in how comfortable people feel in speaking up, particularly, and in challenging staff or providing any kind of negative feedback. And patients want to appear to be good patients because they feel that if they're not, the quality of the care that they receive may be affected. So these are all things that we need to consider when we're trying to involve patients in their safety or in their care more generally. Mel, if you could move on the slide, please. So you all know this. I don't need to tell you about the importance of being able to recognise and respond to deterioration. And it was nearly 11 years ago now that we set out to answer this question: can patients and relatives be involved in recognising and reporting deterioration? Mel, next slide, please. So I guess the first thing to say, and I think I've already provided a rationale for this, is why a patient wellness measure. And the reason for this was that the earliest piece of work that we conducted, the systematic review, as I've said, studied, found a large number of studies looking at rapid response teams and the way that they worked, but there were no studies that looked at routinely recording patients' views. There was quite a bit of anecdotal evidence in some of the grey literature in our conversations with other people that patients and relatives can sense if a patient's condition is deteriorating, so that it might be really useful information to elicit, but there was virtually no research on it at the time. Mel, moving on, please. So we are doing an update of that systematic review at the moment. I will be able to report soon how many studies and how many tested patients' views on changes in their wellness. But at the moment, we still have not been able to identify any solid research that's looked at, other than the PWQ, that's looked at testing a measure of patient wellness in whatever form in a hospital setting. Mel, next slide, please. So the first thing we set out to do was to co-design a measure of patient wellness. It wasn't called patient wellness at the time. It was just a measure of deterioration that asked patients about how they were feeling. And we did this by speaking to both staff and patients, as you would anticipate we might do. And staff told us, well, we already do this sometimes, and not routinely, and we don't record it, but we will ask patients how well they're feeling. And sometimes we might ask them, and how does that compare with other times that we've asked you, are you getting better or worse? We wanted to make the patient measure of deterioration something that staff would feel comfortable doing. And so for us, the best approach was to say to staff, well, what are you doing at the moment? And to try and replicate that. We didn't want it to be onerous. We did not want this to be a 6-10 item measure. It needed to be simple, easy to do, perhaps as part of your practice of doing observations, physiological observations, you would ask these questions alongside, or in some other routine process where you're chatting to patients, a ward round or something of that kind. So it needed to be quick, but it needed to be effective. And so patients and staff, after testing various different types of measures, we had 3 or 4 initially that were similar, but a little bit different, identified that this particular measure gave them information that was useful in knowing how well the patient was, but also how that compared to previous times, so that they could have an indication of whether the patient was getting better or worse. Now, of course, you could ask just the first question, and you could look back at what the previous responses to questions were. And in that case, you would be able to see, well, was the patient getting better or worse? But we wanted to make this a standalone measure, so you wouldn't have to refer to anything previously. You would know in the moment whether this particular patient in front of you is getting better or worse, and whether they were good or bad to start with. So that's where the PWQ came from. It's supposed to be extremely easy and quick to use. Mel, next slide, please. When we did this piece of research, what we found was we thought we might be able to leave some kind of recording mechanism with patients, so like a piece of paper or just a prompt every now and again. And so the researchers did that, but we found that no patients, or virtually none of the patients, recorded it of their own free will. But they were happy to provide the information if asked by a researcher. At this stage, it was researchers that were collecting the information from patients. Moving on, please, Mel. So the next thing we wanted to, we developed a measure. People had fed back that they thought that was quite a useful, easy to use measure. And then we wanted to explore, well, was it actually useful in practice? And to do that, we wanted to identify whether the patient-reported wellness score actually predicted anything meaningful. Now, to use the patient wellness score to predict outcomes, any serious outcomes like cardiac arrest or admission to ICU or anything of that kind, we would have needed huge amounts of data and extra funding. And at this stage, this was being conducted as part of a PhD, so we didn't have that luxury. But what we did know was that news was routinely recorded. And so we thought, well, perhaps we can test whether the PWQ score relates to news recorded at the same time and any future news scores, so that we could see, well, does it predict any changes in physiological measures for patients? And so we worked with some really great units in Hull who were willing to test it out within their routine observational system, and their electronic health record was used as the basis for recording this information. So we worked with a number of nurses and healthcare assistants who are the people most commonly doing the observations, and so recording the patient reported wellness score. The nursing staff and healthcare assistants were invited to record the patient wellness score during the observation for 1 month. And we did an analysis of scores for 103 patients over a period of time, which gave us 500 observations. And we used multi-level modelling because people were clustered within wards, so that's a particularly useful type of analysis to do in those cases. And we were essentially looking here at when you control for the baseline news score, so what we already know about the patient's physiological well-being, when you control for that information that we've already got, does adding in a news score, the patient-reported wellness score, add any new information or predictive ability to predicting the future news score 24 hours later? That was the key thing we were trying to understand here. Mel, if you could just flick on to the next slide, please. So we found that within the same observation, the PWQ didn't predict anything additional in terms of what we already knew about the patient's wellness from the news score. So if you took a PWQ and a news score at the same time, you didn't get any additional information by adding in the PWQ score. But what we did find was that the PWQ was useful in predicting the change in news score over 24 hours in particular. So there was a significant positive association between the patient-reported wellness score and change in the news score, which kind of it was quite surprising, but it was also quite illuminating that patients and relatives can actually tell you something that might predict their later deterioration. And these scores were particularly predictive when the patient did deteriorate. So there was something interesting going on there. Next slide, Mel, please. So what we found was that this initial evidence on these 500 observations, 103 patients, suggested that patient-reported wellness may be a precursor for subsequent changes. And that supported kind of anecdotal evidence that was available at the time. And it showed promise as one way to support staff in the early recognition of clinical deterioration. But this was preliminary analysis. So we recognised at the time that we would need to do further tests of those associations and potentially using other outcome measures as well. Mel, next slide, please. So we've put this together on our Yorkshire and Humber Patient Safety Research collaboration. It's a bit of guidance on choosing your assessment measure, and of course we've suggested the potential of using the PWQ, how to adapt to local circumstances and the importance of adapting the PWQ presentation and use of the PWQ in specific circumstances, and some ideas for how that the use of the PWQ might be supported locally, so how you might go about doing it in your particular domains. Next slide, please. So this is an example from Liz and the team here at Bradford of how they've adapted the PWQ to make it more user-friendly, more available and accessible to a broader range of people, with the use of faces as well as the specific scores. And they have also been collecting data for us to help us ask that same question that I've just reported on again. The problem we now have, and many of you will be aware of this, is that because Martha's Rule is now being rolled out, any assessment of patient wellness is likely followed by some action on behalf of the nurses or healthcare assistants, or escalation where there are serious concerns, which means that any analysis we do now of whether the PWQ predicts later outcomes has that to battle with. There will have been quite possibly some intervention around this. So the next results are provided with that caveat in mind. Mel, if you wouldn't mind. So this was some data that we collected from Bradford, where they've been rolling out, as many of you have been doing, the PWQ. They've been selecting patients at random to be asked the PWQ, and we had a number of observations, again around 340 or so in this case, to look at that relationship between the PWQ and news over the next 24 hours. And you can see in the models here, which I don't expect you to understand in any detail, that again the PWQ does significantly predict news over the next 24 hours, controlling for baseline news, but the amount of variation it predicts is very small now. So we're getting a significant correlation, but it's quite small, and we're unable to say whether that's due to people acting on the information and therefore the later news scores being changed as a result of that or not. But I did just want to take this opportunity to thank Mohammed and Faisal for doing that additional analysis despite these caveats. Next slide, please, Mel, and then I'm nearly done. So what next? Well, we would hope that we could generate evidence and answer various questions together, because I know all of you are collecting news scores. You've got your patient wellness in place now, and it would be nice to be able to explore at scale some of these relationships. The problem we now have with further testing of the PWQ is the one that I've just described to you, that it's likely that changes are being made as a result of the scores and the news. So that's affecting our ability to collect further data and provide new evidence on that. And these are some of the remaining questions. What does asking patients about their wellness achieve beyond detecting deterioration? And I'm hoping the next presenter will be able to tell us a little bit more about that. How can we work flexibly to gain this information from all patients? Is there potential of the PWQ increasing inequalities, and how do we avoid this? How does staff ask about the PWQ? How do we motivate and support staff not only to ask for this information, but to use the information effectively? And then I think the really important point, the last 2 points, are there any unintended consequences of asking patients about their wellness, both good and bad? We could identify patients who are unnecessarily worried and put them at ease. We could help normalise things that patients are experiencing. But information is only useful if we're curious about it. And if PWQ becomes another tick box, which there is a danger of it being, then it's probably not going to be useful for anybody. And I would like to finish there. Thank you very much.
Thank you so much, Rebecca. And it's interesting that last point about the tick box exercise, which is what somebody said at the last meeting we had of this group as well. So definitely something to be avoided. Would anyone got any burning questions? What I plan to do is move on to Dina quite quickly. But if people have got any sort of burning questions, they just want to get off their chest really quickly while we're talking about Rebecca's research. If not, I will swiftly move on to Dina, who's going to talk about some of the practical application within a non-ED setting, but some of the learning that's emerging already. And then we'll pause, hopefully then for a little bit more of a chat and question session between our two guest presenters. Dina, do you want to try and share your slides?
I will do my best to try and share. Bear with. You can see the edit version, I'm assuming.
We can see it on, not on presenter view again, but we can see the slides.
Yeah, it doesn't let me even click the presenter view. I think it's because I'm not the one who organized the meeting.
Oh, how strange. Do you want me to share from mine, or do you want to?
Yeah, I'm happy with if you share. I think you see, that's why I send the email as a backup.
Yeah, always have a backup. Yeah, absolutely. Always have a backup. All right, just bear with me a few seconds. Teams has a mind of its own at the best of times, doesn't it?
Yep.
All right, let me try. Doing some strange things. Let's try again. Sorry, everybody. This is doing something very strange. Try again. Had too many boxes open, it got confused. Right, that seems to be working from my end. Is that shown okay?
Yes, it shows okay. Yes.
Thanks,
can you
Dina.
hear me okay? Okay. Good afternoon, everyone. My name is Dina. I'm one of the critical care outreach sisters at West Suffolk Hospital, and I recently took on a job of the project nurse for Martha's Room. Next slide, please. So 3 components, we all know what they are. This presentation is going to be focusing on component 1. I'm just going to give a bit of data about components 2 and 3 in ED, as we've been doing it for quite some time, just a little bit of data. May I next one, please? So we start Call for Concern a bit different from other trusts. So we went all in at the same time. So May 2024, we just went live for all inpatient areas. And this also included ED, maternity, pediatrics, ITU, NICU, whatever there was a patient, we just went live with it. So I know that different trusts were thriving, that even crossed our minds. We just went for it and started doing it slightly differently. For component 2, we had already something very similar in place for many, many years. So we always encourage staff to contact us if they are concerned, if they feel that they've hit a wall, despite the score of the blood test this patient might have. So this is a bit of a challenge we have at the moment in terms of capturing component 2 referrals, because staff just sent us a normal C-code referral as it is. So unless they use the proper pathways, the new pathways we created, we are counting them as component 2. But we always had the culture of, if you had that gut feeling something is wrong, just send us a message and we try our best to go and see them. Next one, please. So in terms of ED, so since May last year, we had 7 referrals in total from patients that were at that time still a patient in ED. So only one was related to clinical duration. So in our trust, we are sitting about a third is about of the total calls. A third is related to clinical duration and 2/3 are not. So out of the 6 not related, there was one patient trying to get more information about mental health access. There was one about waiting for a bed and not sure when that was going to happen. Personal care, 3 calls about discharge plannings not happening with imaging being done as an outpatient, needing more support on discharge. And 1 call was a repeat activation because we had an emergency. We haven't managed to call them back, so they've activated call for concern again to try and speak with us. Next slide, please. So now focusing on component 1. So we started by doing a trial on F7, which is our acute medicine short stay wards. And then considering that Suffolk has a catchment area with very elderly population, we wanted to make sure that the changes we've made to the previous patient wellness questions were going to fit our population. So we have started beginning of this September a trial on G4, who is our geriatrical care of the elderly medicine. We have at West Suffolk a patient safety initiative called Take 2. So Take 2 is basically 3 times a day, the nurse and the nursing assistant, they get together just to have a very brief chat about every single one of their patients. So, and the idea is to use the 3 p.m. Take 2 to enhance that with the PWQ. And we chose 3 p.m. because our visiting time starts at 2. So we are going to be able to have the relatives and the family present, and the ward teams are still there. So we are not having need to escalate the score or the actions needed to any on-call teams that never met the patient before. So the teams that saw the patient on that morning, they still accountable for that patient. We can just escalate them to them. So in terms of the hashtag, so we are a full electronic digital system hospital here. So we never went on paper with the PWQ. Everything was, we use Cerner, we use eCare. So everything went straight there. So we created a hashtag. So for those who are not familiar with it, on documentation, if you just press hashtag and type patient wellness question, it's going to give you a performer that you don't have to type everything by hand. So basically just gives you a documentation template for you to fill instead of having type everything manually. So I'm very excited because next Monday, so in 4 days, should go live properly on our electronic system for these 2 specific wards. So in terms of auditing, collating data, the information team is going to be able to do half the work I'm doing now manually. They're going to be able to pull the information straight away. So I'm very excited about that one. So the data I'm going to show is about 797 PWQs that I have managed to audit so far. So I am a bit behind with annual leave and short staff and everything. So I'm about a month and a half behind on the audit. So I'm expecting by the end of the year to have 1,000, 1,500 audited. Okay, next slide, please. So this is what our PWQ looks like. Well, the first part of our PWQ. So considering our elderly population, and we have areas, part of our catchment area that have Portuguese, Polish, Indian, Filipino communities, we wanted to make it as user-friendly as possible. And me, I'm Portuguese, so English not my first language either. And we wanted to make this as universal language as we could. So we went from the 5 questions to only 3. And we took the faces away just for the thumbs up. Because as someone who does not have English as first language, it's kind of normally you understand what people are telling you, then you start understanding what you're reading, and then the final bit is for you to actually be able to verbalize your answers. So for those able to listen to English and able to understand it, they could literally just give you the answer on a very simple way. We do have an option if a patient is not able to answer for any reason, that they'll be able to either ask the relatives or have the option of enable. Okay, next slide, please. So in order to be able to then get the score at the end, we've created and pulled a list of soft signs. So the idea is you ask your patient how they're feeling. If they say better, is a score of 1. If they say no change, a score of 2. If they say worse, a score of 3. And then for each of the other soft signs, you give them an extra point. And that's how we have the total score. Okay, so if you go to the next slides, Mel, please. So these are our current version that we are using. So in red are basically the change that we made based on the audit that we completed and based on the feedback from the staff. We have noticed when I was doing the audit that the most common audit was about tired and lack of sleep, which fair. You were in hospital, there was lots of noise. This was tested on acute areas, so there was lots of OBS and blood tests and blood sugars being done on very weird times of the night as well. And there was nothing there about breathing, which with the winter coming is probably going to be one of the most chosen options. So we've also added about breathing symptoms around shortness of breath and sputum production and cough. And then one of the suggestions from staff was to add, was to add something about an inpatient fall on your weakness. So this is the current version that we have at the moment. Our escalation matrix, we have 3 options. If it's a low risk, you continue to monitor. If it's a medium risk, you're going to speak with the nurse in charge and consider escalation to your ward team. And 6 and above is what we count as a high risk. So you're going to inform your ward team if it's out of hours, as in a weekend or bank holiday, you're going to speak with the on-call team, and there's to consider escalation to CCOT. So our own team were concerned about how many more referrals are we going to get? How much it is actually going to increase our workload? So out of almost 800, we had 3 escalations to outreach. So, and we had 1 patient stayed on our caseload for a couple of days because she had an exacerbation of asthma. Another one they referred, but they said, I'm happy that everything is kind of in place just because the score was an 11. They just want to make sure they were not missing anything. So most of the things are being dealt with at the ward level, and that's what we wanted to. We want to empower the teams to be able to deal with whatever came from it. Next slide, please. One of the main concerns of the team was the ward team, because this question is answered by both nurses and healthcare assistants. So the first day I went there was lots of concerns about, first, the patients are all going to say a few words and how I'm going to be dealing with it and how much more tasks I'm going to have to deal with it. And then the other thing is, who is going to actually answer these questions? Is the relatives going to kind of overpower and trying to just answer for the patients? So 99% of the audited ones so far, the patient is answering the question, okay? So for the carer and the unsure, there is 1 per each one of them, but it's just the percentage is so small, Excel just assumes it's a 0. So 1% was family. There was 1 out of the almost 800 was a carer that was present, and she was the one who spoke for the patient. And unsure is just because it's still with the hashtag, so sometimes documentation is not very clear. So that's just, I wasn't exactly sure who asked that question. Next slide is going to basically show the data that we have from the first question. Okay, so 48% said they felt better, and only 8% actually said they felt worse. And considering this was trialed on acute medical ward, I was actually expecting to be the other way around, because people are still on the very early stages of their treatment. The antibiotics are still not even sometimes 24, 48 hours in. So I was actually surprised to see that the majority of the patient felt better. And I've used this data to actually encourage the staff to keep doing it. Considering that the main concern, especially of the healthcare assistants, was that most people are going to feel worse, I kept feedbacking them as I had the data, and they felt more confident in asking the question that was not as difficult as they were perceiving was going to be. Next slide, please. So this is the slide. So in terms of data, what we do is something similar to what has been discussed already. So we look at every single one of the PWQs that is being done, and then I look at it 24 hours after, and I look for any changes in score or any worsening in blood tests. Okay, so this just shows that. So out of the total PWQ score, 73% had a low risk. Out of those 73%, Only 14 had changes in news score, and only 10 had worsening in blood results. The interesting comes the high risk. Even though we are only talking about 11 with the high risk, as in with the PWQ total score above 6, and it's still very small data, which I'm expecting as it goes along is going to give you a bit more confidence in these numbers. But 45% of those that had a high risk, 24 hours in, and they had an increase in news score, and 37 had worsening in blood results. So this does give us an idea that a high score can potentially, using the tool that we're using at the moment, be a good predictor of duration in the next 24 hours. And this is counting with actions already taken, because most of the high-risk ones had something done, either the anti-sickness, or the laxatives, or whatever it was. So these already, even though we are trying to solve the problems, this is counting with that. Our process to implement this PWQ was lots of hard work even before we introduced it. So even though there's lots of media campaign and articles in the news about it, I still found that, especially in our hospital, Martha's Rule is still not a very common thing that people are aware of. And I'm talking about staff. Even though we had big posters in the main entrance, we've been around and call for concern, which the third component has been for more than a year, and pretty much every single ward had at least one call for concern. People are not very aware of it. So what we've done is that even before we've introduced PWQ, I went to wards and I've done multiple visits. So I've explained about Martha's and what happened. I've explained about Martha's Rule. I've explained the 3 different components. I've explained the rationale behind PWQ. I've presented the tool. I was there for questions. And only after these multiple visits, then we actually introduced the PWQ. And I think this was actually something that was very important for us to get the engagement from the wards. I've worked on that ward before. So before I joined Outreach, I was a sister on F7, which was quite handy because I understood how the ward worked and I knew most of the staff. And I think that one of the things we never enjoyed is that you just had a decision from someone to another task on Care Campus that we're going to have to fill, and then someone is going to tell us off if we haven't done it. So I wanted to avoid that, and I wanted to empower people to understand the whys behind that decision and how could this actually have an impact on patients' care. So that's why we did the multiple visits before, and even after we've introduced it, I've done multiple visits after to make sure that people could share concern, could share their opinions and everything else. And I think that's actually the next slide. Sorry, do you mind changing it? So this is just to have a look as an impact that PWQ had on our component 3. So F7 was chosen for multiple reasons to start with, for the diversity of patient and ages and conditions, and also because at that point, F7 was the wards from the entire hospital that had the higher number of call for concern activations up that point. Interesting enough, if you compare the same period from both years. So May to July 2024, they had 7. We started PWQ, we started in April 2025. And then the 3 months after, they only had 1. So it could be related to many reasons. Yes, true. But just looking at these numbers, after we've introduced PWQ on that ward, we had a reduction of 86% on the amount of call for concerns coming from that ward. So this will be interesting to keep looking at it, and then the more wards we have with PWQ and comparing the data. But it's interesting because a very significant reduction on the amount of patients that feel that the ward team are not being able to listen to their concerns. They don't feel listened to, and the amount of activations we had. So this is something that we're going to keep looking at and trying to, as the numbers of PWQs and wards get bigger, we're going to keep looking at. Next slide, please. So this is what I was talking about. So we found different ways, we created different ways for people to provide feedback about it. So I've joined handover huddles. So each ward in a trust, before they hand over patient by patient, they just have a brief view with the entire team about how the ward is, where the most complex patients might be, focus of attention, and they have the teams of the week, teams of the month, something like that. So I've joined those handover huddles, and I was there after we introduced it. So most of the feedback I received was verbal. I was also doing my clinical shifts. I've attended F7 and I was available. If they had any questions, any comments, they could come to me. And I've created a QR code for them to be able to give any suggestions, any opinions without having to speak personally with me. I was expecting to have lots of answers on this, and it has been lots of months. I only had 2. I was like, okay. But I think the fact that I have been so visible on the wards the entire time, and they feel confident to come and speak with them directly, they haven't felt the need to use the QR code. Some of the verbal feedback that I received from the staff is that it empowers especially healthcare assistants when they know that something is wrong about their patients, and because they have the list of soft signs, they don't go to the nurse just to say something is wrong, this patient is not the same as yesterday. It empowers them to be able to put words to that gut feeling that we sometimes have and can pinpoint exactly what it is. And it also helps escalating the medical teams because we are giving them something very specific to work on. Instead of just giving them the total score, we can tell them this patient has a PWQ score of 7 and they complain about the pain is still not management, they need laxatives and they feel sick. So there's something very specific for the medical teams to actually work on. Next slide, please. So when we start looking at the PWQ, there was always kind of our mind that we wanted to have the soft signs joined to the PWQ. We wanted to bring back kind of a holistic approach to patient care. Because we are a full digital system, we spend so much time behind computers just clicking tasks and then clearing stuff that has been automatically ordered and everything, that we feel that it is great. We don't need to try and decipher handwritings anymore or doses on a drug chart, which is a great change. But we wanted to be able to have that holistic approach to care. So we think that the PWQ enhances and helps with that as well. And we have had the report that this does help with communication between the teams. And so far, which I was a bit apprehensive with that, I have not had any doctors coming to me complaining of the new score they have to deal with or a new task that the nurses have to be done. So far, hopefully this continues, I haven't had much resistance from the medical teams either, because we are giving them something very tangible for them to work on: the anti-sickness, the pain, the laxatives, the fluids, something like that. And I think we're pretty much the end, isn't it? I think that's my last slide. Yes, it is.
That's brilliant. Thank you so much, Dina. A few things really resonated, that sort of gut feeling and then that holistic view about, going back to talking to patients, which sounds like a really strange thing, but that's kind of what you were picking up on, isn't it, in that presentation. We have a little bit of time now while Rebecca and Dina are still here, able to carry on the call. If people have any questions or queries, comments. I know I appreciate in the ED, those of you that are working in the ED, obviously we're a little bit earlier in the stage, although I'm sure quite a few of you have been involved in some of the ward work as well. But please feel free to either type in the chat. Lizzie's got the chat next to me. Have we got any queries there, Lizzie, to pick up?
Hi, yeah. I think Tony's asked a question in the chat and Rebecca's been picking that up in the chat. But I wonder actually if it's easier to just have it verbally. So the second part of that, Tony, around, I think your question, Tony, is how we get the clinicians involved. And Dina actually spoke really well about it's not added to their workload, and she's got them involved and they really get behind it. But actually some of the clinicians that might need a different approach to getting them on board. Is that the angle that you're going for, Tony?
Yes, yeah, exactly. I think not knowing how well a PWQ, a patient saying they feel poorly and that they're getting worse, not knowing how well that predicts what's going to happen to their NEWS 2 is a barrier for clinicians. I know NEWS 2 doesn't involve asking patients how they are, and that was because, as Rebecca eloquently said, there was no research base in which to base that on. So they haven't. Perhaps another way of coming at this, in Newcastle's didn't want to initially implement News 2 because they had a version of an early warning score that had this question in it. How are you feeling? But there wasn't an evidence base for that. So the Royal College of Physicians didn't put it into News 2. But I think I guess my concern is that we might be in a position where we never really know what sensitivity and specificity is because, again, Rebecca made this point about now that people are intervening on the back of a PWQ, we're never going to get a study that tells you what would have happened if they hadn't.
I think Tony makes a really good point. I should say that when we were doing this, creating the PWQ and testing it, it was an empirical question rather than we weren't imagining that it would be rolled out across the NHS as part of a Martha's Rule evaluation. And we worked with a statistician who said that given the data we'd collected across the number of wards, that a multi-level modelling approach would be the best method. But I take his point completely that we were answering one empirical question. We weren't answering a question about how would you develop a tool that would be rolled out across the NHS and would be useful to clinicians. And that's a different question and might require different analysis of data. And we'd love to be able to collect, I mean, this is a very, very small sample of patients and observations. And I think to be really confident about the predictive utility of the PWQ, we'd need more data, we'd need a situation that was more controlled, and we'd need different analysis techniques. Tony, you're absolutely right.
Yeah, I agree. If I just make a very quick point to come back, it's not that I think that correlation wasn't a good way of doing it. It was, if the thing had not correlated at all, there'd have been no chance that the sensitivity and specificity were going to be useful. But given that it does correlate, you then think, wouldn't it be great to know what the false positive rate, what the true positive rate is? But you're right, it's difficult to see how we could do it now.
Yeah, because we've got statisticians here that have been working on the predictive utility of news and adding in blood test results and other things, and they're doing exactly that kind of analysis, Tony, that you're referring to. And we've been thinking about how could we do that work with adding in the PWQ, but it, as you say, as we've both said, it's difficult now to see how we would do that.
Yeah. Thank you both. We've got some hands up. Melissa?
Yeah, it was just coming. Hi, Tony. It was just coming back off that. I'm the senior nurse for deteriorating patients at Newcastle Hospitals Foundation Trust. But yeah, that we have News 2 now, so we can produce that number, but we go off a risk score rather than News 2. So predominantly, if there's any nursing concern, or for example, you have like a urine output increase, then it does flag irrespective of the review. So I suppose with the patient wellness questionnaires, if we get any nursing concern or we have other parameters we're worried about, it denotes that review anyway. One of the challenges we've got, as Tony says, is we had a family concern. We've got it running very well in paediatrics, but we haven't quite got it in our adults and maternity yet. So we need a bit of a digital update from that point. But I think some of the work that's been done around the patient wellness questionnaire has been really helpful, because it was just a yes and no question. So it added a risk or it didn't have a risk, where actually I think we can make it a little bit more selective and bring in a bit like Amanda was saying about the soft signs and maybe directing clinicians over. But we have found linking it up, but we have got a couple of our medical colleagues that are doing a bit of research into the blood results and past medical history, looking at SNOMED ICD codes that link up with the News 2, because I know if there's a lot of clinicians and clinical staff on the call, you can usually see the deterioration before News 2 triggers as well. So it's trying to pick up on that. So there is a bit of research going on at Newcastle University into that as well.
Interesting field, isn't it? Lots of people starting work in this area. Megan, sorry, your hand's up.
Yeah, I'm the clinical lead for Call for Concern at East Lancs. It's just going back to that earlier point that Tony made before things started going over my head with statistics and numbers and things. And it was about how you get that involvement from the medical team, and Dina saying they've got something tangible to work on. What I found with our PWQ launch, when we trialed it and asking the questions over 8,000 times across around 4 months, was that actually only a very small amount of time were patients triggering to be seen by a doctor. And by, like Dina did, referring these numbers back to the doctors and saying, actually, it's not going to increase your workload a huge amount, and being able to provide that education as the doctors are coming into the hospital as FY1s or as overseas doctors or starting their registrar training and things like that, by providing that information and by saying, and the interventions that you could provide when you're providing that review will mean that their use score isn't as high in a few days' time, by giving them our local kind of statistics, then actually that is encouraging people to do that. And it's about changing that culture of medical reviews and making sure that the doctors are listening to those gut feelings of the nurses, and making sure that the other way around as well, if the doctors say, well, actually, I've reviewed them, I've done this, I've done that, the nurses are then trusting them as well. So it's about that changing culture as well as just encouraging doctors to do things because of numbers and statistics. It should be about that trust between the teams as well.
Yeah, I agree, Megan. It all comes down to culture in the end, doesn't it? We go around in this cycle, but it's all about those teams working and the strength of the team working well together. Can I ask? Oh, sorry, Louisa.
This is just all really excellent work to hear and listen to. I just had a bit of a question for Dina, and I was just thinking about the. You said that there was 3 that were escalated, and were they escalated solely by clinicians, or were patients and family asking for the escalation? I'm just wondering where, because it sounds very much that, that escalation was very much around, the clinical staff and obviously the soft signs and those things. But I just wondered if you'd get more if patients and families were more aware that they could ask for that.
So these specific escalations to our team was done by the nurses looking after these patients. Some of them, the PWQs were filled by the nursing assistants who then escalate the nurse. So they followed the process as it was. We are in the process of redoing of our comms posters and leaflets and everything, because we started before the national comms from NHS England. So what we're doing now is that each ward, I think each bay, I can't remember exactly if it's each ward or each bay in the hospital, is going to have a poster, an A4 poster with made by the patient safety team, something about use the call bell, fall preventions and something like that. And one of the things that was added was the Martha's logo with the QR code for them to be able to access more information as well. So none of these escalations, the patients, I went to see personally one of the patients after the escalation was made to our team, and the patient felt worse, but she never felt that she was not being listened to. And that is normally the component 3 when we have a call for concern, is normally along those lines. And they feel worse, they feel that they spoke with the nurse, they spoke with the sister, they spoke with the doctors, and no one is listening to them. And none of these activations were along those lines. They were scoring on the PWQ, but they were not feeling ignored. They were feeling that the team were taking them seriously. That's probably why they have not come as component 3. The escalation was just made by staff as component 1, if that makes sense.
Yeah, that makes complete sense. And so I suppose in a way they felt that they were supported and they trust that clinical team just by the sheer fact that they're being asked those questions. So that's a very interesting point in itself, I think. Thank you.
Dina, you had put your hand up. Did you have something?
Yes, I was just going to say something to Megan about the conversation about the PWQs and the escalation and involving different teams. I know this is going to be specific about PEDS, but we use NPUs in our hospital, and we have a pediatric matron as part of our task and finish group for Martha's Room. And she actually suggested that to raise awareness for parental concerns, on their board rounds, before they're going to start the ward round, the nurses are going to start to highlight those children that someone has raised concerns about how they're feeling and not just the staff. That's a way to just bring the team together, and we have lots of board rounds and everything. And one of our future plans is that on our pre-made ward round template that is self-populated with the last blood results, the last vital signs, and past medical history and all of that, in the future is to pull the last PWQ score completed. So once they go into the patients, even if it had not been done on that day, but they will be able to see that. So the change that we made to our electronic record, one of the first questions I asked, because we had to change it halfway through, was, can we still in the future pull these to a pre-populated ward round template? And they said yes. And that was the only way that I said, okay, we can use this version because in the future we'll be able to do it. So the doctors, when they go to review, they can have vital signs, blood tests, and they can have the last PWQ fields. So they know if there's any specific concerns, they can address those straight away. And then we can have again at 3 p.m. the next one.
Yeah. I think we have great minds think alike, Dina, because that's exactly what we're working on at the moment with our data and digital team. Do you use Cerner as well? It sounds like
we
you do.
use, yeah, we have ICARE,
Yeah. Great minds. Thank you for that.
Tiffany.
Thank you. I'll keep it brief because I'm sure you you want to move on. But I just want to say along the lines of, we're obviously talking about the sort of sensitivity and specificity of the tool and all those things. And we appreciate potentially we may have come to a point where we're going to struggle to get more evidence on that. But I would urge people to move away from that being a problem, because what this tool is doing, this is taking us back to what is really important, and that's listening to the patient, and it's making sure that their voice is heard, and it's doing something about the fact that they're feeling unwell and acting on that, and it's doing it in a structured way. Lots of hands going up. And on top of that, what we are seeing, although as Rebecca said, the change is fairly small, it's still there, despite the fact we don't know for certain, but is likely that each one of those high scores had some sort of review and or potentially intervention to prevent the deterioration further. What we are seeing in some sites that have some good local data collection is they're seeing a reduction in their average NEWS2 score on wards where they've implemented the patient wellness questionnaire. So we're getting lots of other measures aside from the sort of the rise in NEWS2 scores. And we'll certainly look at working closely with Rebecca and her colleagues in the future to see what we can do for further research in the area.
It's an emerging field, isn't it? We're all learning, as we've said. Louisa?
This feels really positive in that it's a shift away from using tools as a sole predictor of outcomes. And I think, historically there's been a reliance on that, that whatever the tool says, that's what it says, and that's the action that you take around that. And I'm here from a patient experience point of view. So I had sepsis, and when my GP used NEWS, I scored 4, whereas if they'd used the primary care sepsis UK screening tool, I would have been red light bundled straight to hospital. And had the wellness tool been implemented, then I think there would have been a different outcome, because my CRP was 350 by the time I got to hospital. So, I think things were deteriorating. So it just feels like it's a really important shift. And I just wonder as well if it's important to capture those interventions that are happening as a result of the patient wellness questionnaire, just because that's the evidence, isn't it, that you're taking a different action than you would have done if you'd have just used NEWS on its own, NEWS2. It just feels like that's a bit of an important shift as well. So it's just really encouraging to hear all this work that's going on. Thank you.
It's capturing qualitative as well as quant, isn't it? And the stories that tells us. Absolutely. Gemma.
Hi, I just wanted to kind of reiterate what Tiffany and Louisa have both said, and I think the qualitative data behind what we're finding is probably enough to convince anybody. And I have had people that were really skeptical in terms of thinking that the PWQ was probably not very beneficial, and then when they've seen what our outcomes have been due to having a high PWQ and not necessarily a high NEWS or any other red flag symptoms or concerns, then that they're completely their mind has changed and they're sold. And the other thing as well is I think we have a massive issue nationally at the minute with observations not being recorded correctly. And again, that it's another way to try and pick up them changes that we're not seeing in our observations and that aren't being done correctly. And there's other work that needs to be done around that, I know, but it's a bit of a safety net, isn't it, again?
Yeah, it's all that intelligence, isn't it? Looking at that holistic view, that these things that can help build that picture. Absolutely. Thank you all. It was a really fruitful conversation. So obviously there's been a lot of stuff going on in the chat. We will summarize anything, but carry on typing in the chat any thoughts and feelings. One of the things we are keen to do in any sites who are testing PWQ in the ED, we'd love to hear from you, because as I say, it's kind of people have got some ideas, people have maybe done a very, very bit of small scale, but we're just really interested in the when and how, because we do appreciate the ED is significantly different to a ward, and the processes are different, the places you hook it onto, the points in the process and the reminders to do a PWQ are all completely different. So we're just really interested in learning with you when you're starting to do that early testing. So please do let us know whether you're a pilot site or not, because we really want to capture some of that qualitative. Again, how are you doing it? What are you learning? What the stories coming out? How are the patients feeling? How are we asking those questions? All that sort of stuff that sits below the surface. So please do give us a shout. I'm just going to share just a few slides, and it's just really just a bit of an update for everybody really on what we've learned to date. Obviously we've learned even more today, so I just keep adding to this ongoing conversation that we're having amongst ourselves. So I'll see if I can share again. It's not too many slides. I've tried to keep it slide light today. All sorts of problems with sharing today, aren't we? Let me try a different route. Try and share that way.
Whilst you're doing that, all I can keep in my brain is having been brought up in a Geordie family, does your PWQ have to have canny as a response? How are you feeling? Canny?
We could test that, Sally Ann.
It definitely does in Durham.
Does it? Oh, there we go then. You have a northern version and a northeastern version. What would it be? What would it be in Yorkshire? No, don't answer that. From current slide. I'm hoping that's shared again. Right. Okay, I'm just going to whiz through. So just wanted to, as I say, just build on the shared learning that we've been capturing in the last few months, really. So just to say that escalation pathways, there's definitely not one size fits all. We're finding a huge variation. As we said, components 2 and 3 was kind of seen as less of a challenge, but people are concerned about the PWQ and how it works in the ED, which is why we pulled this webinar together to start that conversation, really. And then we had a big conversation recently around when actually the ED pathway even starts, and what happens to all those people that are kind of in the ED but not in the ED. Are they part of Martha's Rule? Are they not? And if they're not officially, they're going to see the posters anyway, so they kind of are part of Martha's Rule. And we had a big debate about that, so we are wanting to do some process mapping to try and understand some of those routes in and whether patients can and should access Martha's Rule, and the role of all the staff in there in terms of staffing of waiting areas, not just clinical staff, but people like your reception teams and all those people that play a huge role, but often sometimes get forgotten as part of this. And again, people have touched on this today in the presentations, really, that kind of triaging of calls. Not all calls that are for a deterioration line are about deterioration. And similarly, the other side that we've just been unpicking a little bit, and we've just developed a bit of a case study with some colleagues around calls that are actually deterioration calls that are coming in via different routes. So where you've got obviously well-established routes for listening to concerns such as PALS. People know about PALS, been around a long time. People may be ringing the PALS line with deterioration calls rather than the deterioration line with deterioration calls, and all sorts of reasons behind that, where that might be, but just making sure people are cited on that. So is the case, have you all spoken to your PALS team? Are they seeing a rise in calls? And are they seeing weirdly a rise in calls that are slightly different to the ones they traditionally would have got? And how we sort of pull all that together and make sure that we are safety netting everybody, wherever route they come in. Just touching on some work that we did probably about 6 weeks ago now, with one of our patient panel groups, talking about what the term deterioration means to people. It's one of those terms we all band around because it's been been around in healthcare for so long, but actually patients don't really understand deterioration. It was a bit of a moment for my brain. I just went, oh, okay. And then sort of people said, what do you think by when we talk about deterioration? Someone said, oh, it always means death. It's a horrible term. It means someone's going to die if I hear that the patient is deteriorating, not going to live long. This sort of sense of fear and anxiety when we talk about, you know, the deterioration, thinking that something we can do to make that deterioration, reverse it. People are saying, oh gosh, it's the end of the line. So I think it's just about how we use those phrases and terminologies and whether people actually understand what we mean when we talk about deterioration with patients and families. Likely challenges, none of these will be shock to you really, but you know, the impact of ED crowding and extreme levels of on staffing and the acuity going up, particularly as we're moving into winter now. As we've touched on again, how do we communicate this message to all patients? Because we absolutely are in danger of increasing inequalities here if we don't get this right. The complex escalation pathways and unpicking some of that is taking a bit of time at trusts. Handling calls relating to non-deterioration, because we will get them. How do we make sure people get where they need to get to as fast as possible? Someone said to me when that's happening, you know, people getting more and more annoyed because they've rung that lovely helpline and they said, oh, this is a deterioration call, you need to ring somebody else. As I've said, PALS being asked for services, deterioration calls coming in, and then one that comes up time and time again is this calls to Martha's Rule for mental health patients and the impact that could potentially have. But we're really interested to unpick that as we sort of get Martha's Rule rolling in the ED and how we can help those people get the help they need where they need to get it from. Initial change ideas, then people are starting to tell us about these, but please do add this because this is really interesting stuff. Where do we trigger PWQ? Where in the ED journey? Things like, do we have set times and points, such as 12-hour reviews if people are in a long time? Understanding how to ask the question the first time, it's come up a few times. So what is the baseline? Or, you know, do they feel better or worse than what? And then, you know, we need to really start sharing these different types of tools. As we've said, Dina, you shared yours. I've seen many different versions of a PWQ tool, a lot incorporating the softer signs, lots of ways of displaying those. And already, you know, through those testing, we're adding and changing and tweaking those tools because we're learning about how to phrase those questions. We want to learn those with you so we can share them back. And then components 2 and 3, really, all that work around, say, how calls come in, how do we sort of triage them, and how do we have all those pathways to send people where they need to go to get the help that they need within the sort of timescales that we would like to be able to do that by. Understanding different routes and being cited on the different ways that these calls can come in, despite having a well-advertised Martha's Rule or Call for Concern helpline. How do we communicate? Consideration for non-ED patients, as I've mentioned. And as I say, we are hoping quite quickly to be able to do some mapping work around entry to departments, looking at different pathways, where it touches, who it touches, staff involved, non-clinical as well as clinical staff, and that access to Martha's Rule. So ideas for future meetings then, well really we picked up a few in our conversations, but I'm sure there's more we want to hear from you. Role of non-clinical staff in the ED as one, and I think that would be a good one. So if anyone has done work with their reception teams, or they've got some brilliant reception staff that would be happy to talk about what they feel their role is, some of the things they've witnessed, some of the things, pieces of work that they might like to do, then please do give us a shout. All the various places where handoffs happen, we know that's where risk occurs. We've talked a little bit at one of the other meetings around, you know, should we be including ambulance teams, bearing in mind they spend an awful long time in the EDs these days. You know, are they part of our teams? How can we work with them? How can we include them in this journey? And then those pieces definitely we want to focus on around inequalities, learning disabilities, dementia. We have a piece of work going on around the deaf community, which we hope to be able to feed back specific consideration for the deaf community, for the blind communities. You know, we really need to be understanding these and making sure that whatever we do is as inclusive as we possibly can be. But to do this, we need to hear from you, really. We can try and find these things out, but if you know of anybody or you yourselves been working, have some good practice to share, or any specific challenges you just think, I just want to bring this somewhere to discuss this with my colleagues and my peers, as much as we've done today, then do let us know. We can feed those into these meetings. And as soon as we know what they are, we obviously will advertise dates as far ahead in time as we can. So steering group, just to say that as well as this learning community, we do host a steering group. We have a meeting in a couple of weeks, which is basically made up with our pilot sites, our patient representatives, and various other people that we know have a key role and we're really interested in their view in this area. We can take things there, as I said, if common themes, issues, challenges are coming up, that's something we can take and discuss. So again, if you don't want to discuss it here, you just wanted to send it or just tell us about it, we can build that into the agenda for those meetings as well, which happen every 6 weeks or so. My voice is disappearing, I do apologise. It does this when I do meetings. And just to say, we will get these slides out, as we've said. There is a webinar coming up through the NIHR, which is around understanding and measuring emergency doctors' tolerance of clinical uncertainty. It's not specifically related, but bearing in mind the audience coming today, I thought I would just share that out with you. And anything else that we see, we will advertise as well and let you know about. Trying not to bombard you with tons and tons of emails. And then really our email addresses again. We are here. We do want to talk to you. You might have noticed I love to talk. Sally Ann and Lizzie also love to talk. So please do give us a shout. We are happy to have a phone call, have a Teams meeting, whatever, put on an event, as we've said. So our role is to support you and work with you and learn with you, but we only do that if you talk to us. So please do talk to us. We love to talk to people. I'm going to stop sharing now, as I did say there weren't many slides. So we've got a couple of minutes if anyone's got anything else they want to ask or share or feedback. If not, we will give you 7 minutes of your lives back to do other things. And to say we will share the video, the slides, and we'll do a bit of a summary of the question and answers and send that out to you as well, so you don't have to trawl through everything. Make lives a bit easier. But huge thank you to our lovely speakers, and thank you for staying on the call. I know that either you were sure you could do, so that's brilliant. I know, Dina, you've got a son at home with you, a young son, so it must be quite a challenge. So thank you so much, and thank you so much, Rebecca, as always, for all your expertise and taking us really back to where this all came from, which is just, I'd forgotten it was that long ago, 2016. My life is going way too fast at the moment, but it's a long journey to where we've got to, and it's just really nice to see it sort of, I guess, blossom into this this huge piece of work, but just all the work, all the good we can do as we're implementing this in practice. Brilliant. If there's no more questions, sorry.
Yeah, or put in the chat any ideas for future
Oh gosh, yes.
learning communities, or email us in. But yeah, we'll keep the chat open for a bit if you've got things that you'd like covering.
Or things you want to tell us about.
Yeah, absolutely.
You're being brave. Other than that, lovely to see you all, and we will see you all shortly, hopefully.
Thank you.
So please do give us a shout.
Thanks, Mel. Lovely to see you again, Sally Ann. See you soon.
Yeah,
See you
likewise.
soon.
Bye.
Thank you.
Thanks, everybody.
Hi, Rebecca. Did you put your hand up?
Thank you.
Oh, just a clap. It's all the little emojis, isn't it? What hold means, but
That means another meeting.
I
If you
can
just stop recording and then we can.